I would now welcome our chairperson for this session, Dr. Jigar Desai from Ahmedabad and Dr. J.S. Anand from Ahmedabad.
Good morning.
I would now request our chairperson. Yeah, good morning, sir. I would now request Dr. Jigar Desai to introduce our first speaker.
Good morning, respected speakers. I would like to introduce Dr. Hemant Thacker. He has done his MD from Bombay and has numerous degrees with him. He is working at present at Institute of Rich Candy Hospital. He is consulting physician, cardiometabolic specialist in medicine. Thank you. Please, sir.
So, good day, ladies and gentlemen. I want to thank Dr. Mayur Patel and Dr. Mona Shah, the chairman and chairperson of SwasthyaCON, for giving me this opportunity to participate. And of course, the other office bearers, Drs. Patel, who have also worked so hard to put this lovely meeting together. My topic for today is targets for glycemic control, which incorporates the legacy effect and the glucose lowering effect. Remember, everybody knows what the targets are and what legacy is all about, but we have to come up with what is the latest and remain abreast with the changing times. And since SwasthyaCON is in 2021, which is changing every day as we speak, we have now incorporated certain key changes. The addition of target category of functionally dependent patients, in whom we target 7.1 to 8. We lower the FPG and PPG targets in individuals not meeting the A1C target of less than 7. And the strengthening of the recommendation for targeting an A1C of less than 6.5 in people with type 2 diabetes to further lower the risk of CKD and retinopathy if they are at low risk of hypoglycemia based on the class of agents, OHAs, and the patient's characteristics. Now, remember, let's look at the targets checklist. A1C less than 7% is valid for most people with diabetes. A1C less than 6.5 for some people with type 2 diabetes. And A1C between 7.1 and 8.5 in people with specific features. Now, like I said, most adults with type 1 or type 2, we would look at less than 7. Adults who have type 2 diabetes, in order to reduce the retinopathy and the nephropathy risk, if the patient is at low risk of hypoglycemia, target to less than 6.5. And from 7.5, you can keep going higher, especially in the functionally dependent patients, where there is recurrent severe hypos or hypo-unawarenessness. There is limited life expectancy. He's a frail elderly patient and or with dementia and no help. So avoid higher A1Cs to minimize risk of symptomatic hyperglycemia and acute and chronic complications. Just because we've pulled the string from 7.1 to 8.5 doesn't mean we can stretch the rubber band beyond and for long. So at end of life, A1C measurement is never recommended. All you want to do is avoid the two troughs and the peaks, which means hyper and hypo. Now, to achieve A1C of less than 7 is most patients need a prebrandial of between 4 to 7 millimoles per liter and a post fasting of 4 to 7 millimoles per liter and a fasting and a post lunch of 5 to 10 millimoles per liter. So prebrandial of fasting would be 4 to 7 and postprandial would be 5 to 10. But if A1C is still not achieved, you have to pull down the prebrandial and the postprandial, which becomes 4 to 5.5 and 5 to 8 respectively. And if you look at the correlation between A1C and estimated mean glucose values, you can see very clearly that the estimated mean glucose values for 6.5 to 6.9 is 7.8 to 8.5. lower values and higher values, it would be worth keeping this chart. Let's look at less than 7. We all know the effect of intensive treatment for diabetes on the development and progression of long-term complications in IDDM, insulin-dependent diabetes mellitus, where intensive and conventional treatment. So if you look at the early intensive glucose control, which leads to long-term reduction of non-fatal MI, stroke or CVD death, you can see how there is a 57% risk reduction, which is very, very significant. And this is important when you compare the conventional treatment with the intensive treatment. We now move on to the early intensive glucose control, which leads to long-term reduction in mortality. The conventional treatment compared with intensive treatment, the intensive treatment holds out longer and begins creeping up much later. And if you see the UKPDS, intensive glucose control with sulfonylureas or insulin in type 2 diabetes, a cohort of about 4,000 patients, how intensive scores over conventional. So if you look at the legacy effect of early intensive glucose control and look at the aggregate endpoints, any diabetes related endpoint, we have a p-value. Microvascular disease, we also have a p-value. We may not have p-values for MI or all-cause mortality, but definitely these two, we have a significant p-value. Which brings me to the lower end of the spectrum, less than 6.5, the advanced study, where intensive blood glucose control and vascular outcomes in patients with type 2 diabetes using gliclazide MR with an aim to bring it down to 6.5 versus standard glycemic control. And you can see here the standard control is 7.3 achievement and intensive control is 6.5. It's a pretty large follow-up in months, going up to 60 months plus. And the treatment outcomes on the primary microvascular outcome study, intensive versus standard, look at the new or worsening nephropathy and retinopathy, and you get your answer. Very clearly seen there. But if you look at the scales between benefit and hypoglycemia, that's why I take you to the other end now, where we push patients to 7.5 plus, all the way even up to 8.5, especially depending on their frailty score. I'm sure all of you know what the frailty score is. I've put it up for observation. And earlier and more aggressive intervention may improve the patient's chances of reaching goal. Now, if you see here, the published conceptual approach of diet, one drug, up titration, second drug, up titration, basal insulin, and then finally reaching, so many years have gone by, and you get a yo-yo and a zigzag of all the A1Cs. As against if you begin early, where the duration of diabetes is completely not lost in this titration going up from 1 to multiple. You can see very clearly that all these can be conceptualized and synchronized to begin much early and follow the black line. And this paradigm shift in the management of type 2 diabetes, let's go from left to right. The most intensive would be 6, less intensive 7, and least intensive 8. All of this depends on socio and psychoeconomic considerations, the hypoglycemia risk, the patient's age, the disease duration, comorbidities, established vascular complications, and what else the patient has in and around the patient. A highly motivated, adherent, knowledgeable, excellent, self-care capacitous patient is different from a non-adherent, less motivated, weak support system, poor self-care capacity. And if you see here, a classic example of a couple from the West, 79-year-old man with CAD, CABG, diabetes, more than 20 years, prostate, hypertension, osteoarthritis. Though he is independent in his day-to-day work, his daughter helps with groceries and cleaning. He's a doting husband who looks after his wife who has Alzheimer's, and he's coming to your clinic regularly. What target would you set for this man? And if you select any one of these, you'll have to go into all the summaries which we have. Remember, the only red arrow here is accord, where if you push, you can get mortality increase. UKPDS, DCCT, EDIC, accord, advanced VADT, you can see microvascular reduction across the board. Mortality, well, UKPDS has shown a drop. CVD, of course, UKPDS and EDIC has shown. The others are equivocal. So if you were to apply this data to Mr. Smith, look at his age, he doesn't fall there. Look at his duration, he again doesn't fall there. Can we apply the data to him? Again, achieved HbA1c, look at that. Look at the ACCORD study where there is a decrease in non-fatal MI, but an increase in all-cause and CV mortality. Or the STENO2 study. Look at all these studies. And it is time to derive benefit from this knowledge. And benefit versus risk for Mr. Smith, you have to see where you want to look at tight control, loose control, relaxed control, and put your data together. Because factors favoring tight control for Mr. Smith, who has a 20+ history years of diabetes, who is 79 years of age, put your data of UKPDS, VADT, advanced ACCORD together, and you will see that the rates of estimated hospital admissions for hyper and hypoglycemia among Medicare beneficiaries with diabetes spanning over a decade showed that hyperglycemia and hypoglycemia were both there, but it was hypoglycemia that scored in its admissions. One has to be very careful of it. So most likely patients at that age are likely to be admitted with hypo rather than hyper, and hypo rates were twofold higher for older patients. Survival as a function of HbA1c in people with type 2 diabetes, the graph again swings down at a lower age, but bobs up at the higher age. So if you come back to metabolic memory and glycemic legacy, looking at UKPDS and VADT, you can start intensive therapy. With intensive therapy, you drop the A1C nicely and rapidly. That would be the ideal course, early and sustained glycemic control. If you didn't start it, or if you started it and you missed out, you again start climbing. And that's what happens, is where you have to resume the early intensive therapy like they did in VADT. UKPDS was different, and in VADT, they had to do it at a later stage, and that brought it down again. And the risk of complications continued in this group despite glycemic control. And the risk of complications continued because the legacy effect was lost. So this is important. That is bad glycemic legacy. And that is what drives the risk of complications. Legacy is an inheritance, and if you, it's like an upbringing. And if you don't nurture and bring up your child well, he's going to grow into, no matter how much you correct him after 5, 7, 10 years, he's growing to grow into a ill-fitting individual. The same thing happens. No matter how quickly then you try and bring it down after 7, 8 years, that inherited bad legacy is going to haunt you in the form of complications. So especially in the older adults, the consensus is a healthy patient remaining longer in life for expectancy come to under 7.5. Multiple coexisting chronic illnesses or ADL impairments where the patient has high expectancy, which is intermediate, and the patient is hypoglycemia vulnerable, stay under 8. And if it's the end of chronic illness, limited life expectancy, lot of impairments, stay under 8.5. The conclusions is choose your targets and go for goals with the window of opportunity. Titration does not work in clinical practice. Don't treat to fail. आज एक ऐड करेगा, 2 महीने के बाद नहीं चला तो उसका डोज बढ़ाएगा, उसके बाद दूसरा ऐड करेगा. You don't treat to fail. You choose your goal and you straight go to hit the goal. Remember, titration is where fail to treat. You keep titrating, you fail. It's a slow and a difficult task. Overcome the clinical inertia. Use in the beginning maximum dose as much as you want, multiple drugs, combine drugs, good doses. And of course, when you combine, you can bring down their maximal doses. So use maximum drugs with minimal doses, but use combination depending on your goal to reduce the complications. And we now have tools to target the risk factor for CVD in diabetes and metabolic syndrome. So still a large proportion of morbidity and mortality, and choose therapy and goal based on risk stratification. I think we don't want to give you numbers and dictums to follow. Once you've got your goal in mind, go at it with hammer and tongs. Bring the A1C down first by hook or by crook with as many drugs as you want, and then start pulling out if you find you have reached your goal and the patient is adherent. That way you will not give him a bad legacy. I think treat is for success and not for failure. That is the most important thing. Thank you for your attention, and I'll be happy to answer question and answers at the end of the session, whenever the session concludes. Thank you once again.
Thank you so much, Hemant sir, for your discussion on the topic lack of legacy effect in modern glucose lowering trials.